It's wonderful to be here with you all today. I'm Deb Werner, Senior Program Director at Advocates for Human Potential and a woman in long-term recovery. I've been doing this work for upwards of 2 decades, and I'm very excited about the sessions that we have for you here today. Before I get started, though, let me introduce you to Jean Pulvermacher, the co-director for the Great Lakes Addiction Technology Transfer Center, for a few opening words. Jean?
Thanks, Deb. So happy to be here. Like Deb said, my name is Jean Pulvermacher, and I'm the co-director of the Great Lakes Addiction Technology Transfer Center. We are located at UW-Madison, and we are funded by SAMHSA to help people and organizations implement effective practices for substance use disorders, treatment, and recovery. We serve Region 5, Health and Human Services Region 5, which includes Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. We're so happy that you're here today. If you're not familiar with the ATTCs, just to let you know a little bit more about them, there is a website. It's called attcnetwork.org, and from there you can find your region. Ours is the Great Lakes region, which we're working with today. But the network and mission and vision of the ATTCs is kind of to unify science, education, and service to transform lives through evidence-based and promising treatment and recovery practices in a recovery-oriented system of care. We're working with AHP to bring this Pregnant and Parenting Women series to you. We did some work with this population last year. It was a big hit. AHP partnered with us as well. And we had some folks that wanted some follow-up, and so here we are. I hope you can join us. We will have 2 more sessions throughout this summer here. We'll make sure we get the information to you. But with that, I just want to say thanks so much for joining, and I will hand it back to you, Deb.
Great. Thank you. And thank you so much for hosting these webinars. It's really been a wonderful experience. Last year's webinar was called Understanding and Making a Difference for Pregnant and Parenting Women with Substance Use Disorders. And then we did a learning collaborative for managers and directors, people who are working directly with pregnant and parenting women, that I think was very well received. So we were really happy to have the opportunity to come back here. When we were thinking about, so what is it that we want to do? We've already done kind of the general sessions and thinking about sort of what are current trends, things that people need. We've identified sort of topics around, so today's topic around marijuana, really kind of honing in, because, you know, I've mentioned that I've been doing this work for upwards of 2 decades. The drugs have changed, the services have changed, the policies have changed. So it's important for us to be paying attention and being current in how we're thinking about and how we're the kinds of services that we're delivering. So marijuana is one of the topics. Then we're going to have a session. Our next session will focus on FASD and alcohol-related issues, particularly not just related to the fetal, but also as women age, some of the implications of fetal alcohol spectrum disorders. And then our third session will focus on pregnant and parenting adolescents. So we're looking forward to delivering the series as well as the learning collaborative, tell you a little bit more about that in a few minutes. But just to get us started, I'm very excited to introduce our 2 presenters for today, Linda Frazier. And Linda and I have had the opportunity to work together now for about 10 years. She's the Director of Addictions Initiatives at AHP and has more than 30 years of leadership, consulting, and clinical experience in a variety of settings, including outpatient behavioral health, medications for addiction treatment, women's health, adolescents, college health, and she also served as the Director of Treatment and Recovery Services for Maine's Department of Health and Human Services. So she has that big picture as well as the direct clinical experience and knows so much and is so passionate about pregnant women. Linda also served on the leadership team of the American Public Health Association Alcohol, Tobacco, and Other Drugs section. Since 2009, she's currently the past chair, and she was the lead author of both of their 2013 and their 2021 APHA policy statements on public health and cannabis legalization. So she brings both the direct experience working with pregnant and parenting women with substance use disorders and that policy kind of experience into the work that we're doing. So very, very happy that Linda is here to join us. I'll introduce Carla later in the session because she's going to be giving some of our case presentations as we move forward. Before we get too started, let me just tell you a little bit about our learning objectives. I do want to encourage everybody to put questions in the question and answer box so that we make sure that we are addressing some of the things that you really want to see addressed. We're going to talk a lot about perceived risk and predictors of cannabis use in pregnancy. We'll also talk about how some of the key factors for educating pregnant women about cannabis use, and then some of the treatment considerations, some of the concerns related to cannabis use in pregnant women. So we'll make sure that we're covering a lot of different areas. We have a very diverse audience here today, and it's a really exciting group. Before we get started, if I could ask Beth to pull up this poll, let's just kind of get our gears in place, because as I mentioned, things have changed, right, from where it used to be. So the question is, my organization has clear policies on client marijuana use. And it's always interesting because I can actually see the results kind of as they're coming in. It's starting to slow. I think we can go ahead and close the poll and share the results. So as you can see, we do have some organizations that do have very clear policies. They may not be good policies, they might be phenomenal policies, but do have policies. And then we have a lot of organizations, almost 2/3 of you, do not have clear policies on client marijuana use. And this goes, I think, to how we're in this kind of transitioning point, right? So you probably do have clear policies around alcohol use. As marijuana has changed its state in a lot of different states, it's time for us to kind of be catching up. So that's part of what we're really here to talk about today. I'm having trouble. I'm not sure how I get rid of this poll. Here we go. And actually with that, I'm going to go ahead and turn it over to Linda. And Linda's going to give a presentation. We'll stop for questions periodically. So again, if you have questions, put them in the box. And with that, I give you Linda Frazier.
Hello, folks. I'm really pleased to be here and really excited to be able to share some of my experience and hear what you're struggling with and how you're addressing this. And hopefully it can lead to more sharing, because I think we raise the boat together by learning from each other's successes and challenges. So want to start by just saying, a lot of people ask me, why do you do a disclosure slide? This is just a webinar. I've been in the cannabis space long enough now that it's really important to stop and take a moment and think about this. So industry influence is large in alcohol and tobacco, and now in cannabis. And frequently when I facilitate conversations or trainings or discussions at the American Public Health Association or at the 2 research and public health cannabis conferences we co-hosted and did with the UCLA ISAP, ATTC in California, or, with colleagues. There's always this perception that somehow the reason I'm talking about this is because I'm pro-legalization, or why do you not sound like you're anti-legalization? Do you work for the industry? So you're going to hear me use very neutral language. You may have moments when you think I'm advocating for something. I assure you, I will be clear if I'm recommending something. But I'd also ask you to just pause and be aware of your own beliefs and experiences as you come into this training, and recognize that I may share information that's new with you, that's different than what you thought. or different from your own experience, or that you may see questions or hear discussion that's very different from the conversations you've been having. And I just want to acknowledge that up front. I think that's okay. This is a great learning environment, and hopefully we learn from each other. So without further ado, we'll move forward. So want to start with just getting people on the same page. I'm going to have a few slides here that just sort of give an overview of the current landscape, which is changing as we speak, right? So whatever your position is, whatever organization you're in, whatever state you're in, things could look very different. And that's kind of the state of the states. So a few key terms here, most of which you may be familiar with. But one of the things you'll notice is I talk about cannabis. I don't tend to use the term marijuana. That's partly driven by the states I've worked in. It's partly driven by the history of cannabis regulations in the US and some of the inequities and disparities that have been reinforced by policy decisions that weren't always transparent or research driven. I'm not judging you if your state calls their Office of Marijuana Policy, then that's what you're probably going to use in your state. So there's no right or wrong, but it's really good to be aware of the fact that people use the terms interchangeably. And when we're talking about adult legalization and medical legalization in the United States, we're talking about THC in a product, cannabis product, that's over 0.3%. We'll talk a little bit more about the different components of cannabis as we move forward. But legally, when a state chooses to legalize, the issue of what's legal and what's not legal at the federal level and what happens when states legalize is really based on this 0.3% or more THC in products. It's also worth differentiating between medical cannabis and adult use cannabis. The trajectory states have for legalization is usually decriminalizing, then maybe allowing medical use in some way, shape, or form. And then eventually we've tended to see most states move towards adult use. So medical use is a bit of a misnomer. There is no cannabis medical prescribing that can happen unless it's a actual pharmaceutical product like Marinol. And Marinol is legal and Marinol can be prescribed. But when we talk about medical use, states put in place regulations that allow people to get certified or get a card or get deemed appropriate to use medically. And those regulations look different in every state. And those regulations may look very different than adult use. And adult use is when you legalize for non-medical purposes. You don't have to have a medical condition. It can vary, how this looks can vary state by state. You have the state of California where the regulations give counties a lot of authority. You have other states where it's all driven by a bureau at the state level. But the regulations for medical use and adult use can be very separate and different, even when it gets down to packaging, labeling, and advertising. So for example, I do a lot of work in the state of Maine. Maine's medical use market has no oversight of packaging, labeling, and advertising. The adult use market is very restricted. You can't get into an adult use store unless you have an ID and you're 20 years old, 21 years old or older. And so these things can look different depending on state regulations and statute. And then last but not least, we need to acknowledge that cannabis use disorder is a defined diagnosis, whether you're using ICD-9 or you're using DSM-5, you're doing screening and assessment, and you're working with patients, or if you need to be persuaded by the research that actually cannabis use disorder is a thing, which some people have felt like it isn't as big an issue because we haven't seen it rates or prevalence be as high. So wanted to ground us in what we know from broader research here in the US. And the National Academies of Medicine was tasked with doing a comprehensive review of the research in and about cannabis and its health effects. In 2017, this report was published, but they reviewed all the current literature from 2011 forward to 2017. And this really is the most comprehensive research that we have available. It's the links to anything that I refer to are on the resource slides that you will get. But the National Academy of Medicine was tasked as a group of experts to analyze the research on health effects, both whether there was evidence for therapeutic effects or medical applications of cannabis, as well as what are the adverse health effects or the risks or reasons that people should not be using cannabis. And so on this slide, what you see are those two categories outlined. Now, the Academy of Medicine not only reviewed the literature and research, but they graded it. They identified whether there was substantial or conclusive research on a therapeutic effect or a health effect, or if it was moderate to limited or even no research supporting a health effect or an adverse effect. So what you see on the slide is the stuff that's got more robust research behind it. There are actually about 240 different conditions where there is evidence for therapeutic effects from cannabis use. But the ones that seem to have the most robust evidence and seem to bubble to the top as real and true research-based therapeutic effects are pain relief, nausea relief, particularly with HIV and cancer, treating the symptoms and spasticity of multiple sclerosis, appetite stimulation, again, for people like who have chronic HIV or cancer or conditions where appetite is a problem, and then as a sleep aid. So those are supported by research, but there are also adverse health effects. So just because it says there's nausea relief as a therapeutic effect, the report also is really clear that it's not okay to use cannabis during pregnancy. It's probably risky for people with mental health conditions to be using cannabis because it can induce psychosis. That there is a risk of dependence and addiction developing with use. That youth under the age of 21 should not have access and should not be using. And that use can increase your cardiac risk, particularly if you already have cardiac issues, and that it can lead to injury. We think probably the most common injury related thing we talk about is either driving under the influence or exposure unintended exposure by kids or adults at doses that have negative impacts. So what does it look like at the state level? And again, just trying to ground us in the background. Here you see across the United States, the dark blue states are states that have adult use dispensaries where there are sales to adults of marijuana products that are over 0.3% THC. The lighter blue states have medical use legalization. Those gray states are states that have what we call low THC programs, where they've said as long as you don't go above a certain threshold of THC or CBD, all products that are below that threshold are legal. Then there are a few, like only a few, lightest colored states, Idaho, Nebraska, and Kansas, that have total prohibition. They have not decriminalized and they have not legalized either medical or adult or even low THC. One of the things that's important to remember, I guess I forgot Hawaii and Alaska down there, sorry. So there's four states that haven't legalized. The thing that we need to recognize is, as I said before, all of these decisions are separate and distinct. They're policy and statute and regulatory changes that happen at the state level. And even if the industry is not involved in writing regulations, legislators can make changes to what finally goes into law or into regulations or into licensing requirements. So some of the products that you may be familiar with or you may not be familiar with, but I wanted to just do an overview of is, these are some of the things that are being produced and sold both in the medical and the adult use markets. And because of the federal status of cannabis being illegal, it is not regulated by the FDA. It is not, there's no federal rules or regulations around testing products, about labeling products, about packaging of products, about advertising. There's not an ability to do research on some of these higher potency products because of the DEA oversight of research on cannabis, which mandates DEA approves it, and all of the product that is used for research is grown on a farm in Mississippi. It's traditional plant, and it is not, the DEA oversight doesn't allow testing and research on high potency products. So even though I'm going to talk about these products, and we've talked about anything over 0.3% being what's regulated or legalized at the state level, there's not a whole, it's kind of like dietary supplements. There really is no federal entity that can oversee the products that are being produced and sold at the state level. So the only oversight is what is in the regulations and statutes at the state level. And these are all products that can be legally sold in states that have legalized. My guess is I've left things off here. You may have seen or heard of other products. And we will do a little bit of a deeper dive on some of the vaping and e-cigarette issues. But we're seeing even alcohol with THC in some locations becoming very popular now. The other piece that is really important to acknowledge is once a state legalizes, there are products that are sold or can be gotten on the illicit market And then there are these other products that aren't necessarily what you expect, or we need to be clear, not part of the legal regulated market. So synthetic marijuana is K2 or spice. It's a man-made chemical product that is psychoactive. It's not very safe to use, but it also, because it's not real cannabis or THC, it's not detectable in urine drug screens and some of the drug testing. And so it tends to be something that teens will use, or people that are trying to avoid a positive test might be using. Really important to acknowledge that there can be mixtures of CBD and THC, or tobacco and cannabis, or people using illicit substances and mixing things together. And those are not necessarily products that are part of the regulated market. CBD products are legal, as are Delta 8 and Delta 10 products that come from hemp, because they have less psychoactivity, not zero psychoactivity, but they seem to be at very low levels in hemp. The reason I point them out is there are people out there producing illicit products from hemp in states where hemp is legal, and those products aren't tested or regulated, and can have psychoactive effects. And then I wanted to talk a little bit about prevalence, and particularly with pregnant women. This is from a SAMHSA report. We've given you the link to this report. But when we talk about smoking and use of nicotine and cannabis, what we tend to see are that pregnant women have somewhere around 13 to 20% of pregnant women seem to be using nicotine. And about 23% of those that are using are continuing to use during pregnancy. And I'm using nicotine rather than talking about smoking, because many people, not just pregnant women, have really perceived as of using nicotine products as safer because they're no longer smoking a hot cigarette. The vaping and hookah and water pipe craze has really changed people's perception of both nicotine use and cannabis use. So when we move to cannabis use, and we're talking about use in pregnancy, depending on the study you look at, 2 to 5% of women who are pregnant are using marijuana overall. Of that 2 to 5%, we see that about 34 to 60% of them will continue to use cannabis during pregnancy, frequently because they don't think it's a risk, or they believe that it truly is a benefit to be using. And what's interesting about the prevalence rates is if you look at subpopulations, younger populations, urban populations, or those with a lower SES, that 2 to 5% increases up to 15 to 20%. And it's pretty safe to assume that maybe those that continue to use during pregnancy would be at that higher end of the 60% rather than the lower end of 34% use during pregnancy. So again, this slide is talking about nicotine and vaping during pregnancy on the left, and specific to cannabis use on the right. And the reason I put it all on one slide and wanted to really spend a moment on this is because we don't have good research on how much of this is co-use. We just have very discrete research that gives us measures of use of nicotine or vaping or use of marijuana during pregnancy. So there's a lot of room for more research. So why is marijuana use so prevalent? There's a lot of reasons. You could probably put in the chat loads of reasons. You believe it's more prevalent, or what your experience has been at the state level, pre-legalization or post-legalization. But want to talk a little bit more about perceived risk. And I think it's important to spend some time on this as we think about why people believe it's safe. So perceived risk is an individual's subjective assessment of what a particular behavior, what the risk is of a particular behavior, right? So perceived risk can apply to cannabis or can apply to any behavior. And some of us are more risk tolerant. Some of us enjoy downhill skiing. Some of us enjoy driving at high speed. Some of us are more risk averse. So perceived risk is not only driven by information that you have, beliefs you have, your own experience, what you've been taught or seen modeled. But perceived risk can also be tied to our own personality. You know, are we somebody that has a high tolerance for risk taking or not? So why is this important with cannabis and cannabis use with pregnant and breastfeeding women? Well, cannabis is the most commonly used illicit or licit drug in the United States. Depending on what state you're in, it's illicit or licit, legal or illegal. And with this move towards decriminalization, medical legalization, and then adult use legalization, there really is this perception by most Americans that this is a drug that is fairly low risk compared to other drugs, which is the exact opposite of how we have scheduled it in the Controlled Substances Act, right? So Schedule 1 in the Controlled Substances Act at the federal level says that cannabis has no medical use and it's highly addictive, and it's in Schedule 1 category with heroin, right? So even Oxycontin, oxycodone, Valium, benzodiazepines, none of those are considered to not have medical value and be highly high risk for abuse. So the perception and our credibility around these issues in the United States are a little bit problematic. And we're not funding education and information programs to impact this. So when somebody perceives cannabis as low risk, we actually know from research that they're probably about 6 times more likely to use it in the past year than those individuals who say actually they perceive cannabis use as risky, whether it's because they perceive it as a risk for psychosis, cannabis-induced psychosis, or if they have been educated and feel like it's a risk to their brain development or their cognitive functioning. And so what becomes important as you're working with women who are pregnant and breastfeeding and parenting is we really have to start having discussions and asking questions about how people perceive the risk of use of cannabis, and what do they think, or what have they heard, or what were they told by their community, and do they actually see cannabis use as a reduced harm because they've been using other substances, so cannabis is safer, or do they actually see it as a medicine that's really important for their health and well-being? Those are beliefs people can have. And we need to understand if that's the case, if we're going to engage meaningfully with people about their use and about our recommendations or our policies and procedures in your organization or treatment facility that says use is not allowed. And this last piece is really related to this vaping issue, that this idea that smoking cigarettes is no longer safe has really gotten across, and smoking rates in the United States have dropped significantly. But what that doesn't really capture is the fact that many people have moved to vaping of some form because they see it as being less risky. And in fact, the research shows that it is less risky, but that doesn't mean that there's no risk. And getting to wrapping up on sort of this overview, because it gets a little bit too didactic, but the last piece that's really important and involved in perception of a risk is information and misinformation. And of course, we've all, as a country and as a world, been dealing with this issue of how do we fact check? How do we know if something's real? What's being posted on social media? What is the media saying about things? What are they reporting? Are they reporting both sides and then people are picking what aligns with their current belief? But misinformation in the cannabis space is really important to address and to be aware of. I said this earlier, but when state legislatures finalize their regulations and their statutes, they can be influenced by lobbyists. They can be influenced by people that donate to their campaign. And they can be influenced by people in the community that really believe that cannabis has been important to their health and well-being as a medical user. And that can influence what things get legalized as appropriate for medical use. Legislators are not well known for doing the research. They rely heavily on the people that advise them. And so medical markets, there are no approved uses in medical markets around pregnancy or breastfeeding or treatment of nausea, but people can believe these things, and people who are dispensing these products in the illicit market or the legal medical market can be giving information that's contradictory to what the research says. And then there's just this issue of supplements and natural remedies. People come with beliefs and experiences that influence their decisions around what they think is going to be helpful and treat, or what their family members or community members may be recommending to them. So before we move on, I wanted to pause and just take a minute and see if there are any specific questions. That was a big overview. I apologize. It's kind of dense, but it's hard to summarize all of that and what's happened over the last decade.
Hi, Linda. We do have a question that somebody is asking if you could talk a little bit about equity and history of racism and how that is affecting some of the pieces around cannabis policy.
Sure. So part of there are a number of different influences to the move towards moving from complete prohibition to decriminalization to legalization. And some of that has been emerging research across the globe. Some of it has been really social beliefs, people in the United States believing that we should no longer make cannabis illegal. And the other piece is the drug war, or our policies around drugs and arrests and incarceration. and the fact that there have been real disparities in how any and all of our drug laws have been applied to populate brown and black individuals in our country. And so all of those things come together and have really raised the issue of equity in the legal markets. And it gets lost in the noise around people's disagreements. But even if when a state legalizes, they say we want this to be equitable, tax revenue doesn't come in and funding isn't there for expungement of records, clearing criminal records so people can access public funding, equity in terms of access to work has been an issue in this. And so there are a lot of folks that are lobbying that cannabis legalization workforce should prioritize equitable access to training and workforce or ownership of dispensaries. So equity is an emerging issue in public health and really has to be at the center of all we do in public health. But in the cannabis arena, it's really taken on a policy edge. And I'll talk a little bit more about that as we do a little deeper dive.
That's the only question that we have right
Okay.
now.
Well,
And
so
I'll
I'm
send
going
a reminder to people to go ahead and put questions in the box.
Thank you. We'll also do some questions at the end. So make sure you're capturing what questions you have. So I'm going to move a little faster, not because I don't think this is important, but I think the next parts are things that people are a little more aware of or have had information on. So language matters. I talked about that in terms of marijuana and cannabis and some of the disparities in racist policy decisions that have been made. But it also matters when you're trying to have good conversations with people. So, if you've got a question on your screener that says, do you smoke? And somebody says no, I'm not sure you now actually know whether they use nicotine or tobacco products. If you just ask if they smoke, do you ask if they use cannabis? Right? So you need to distinguish between what is it that people are using and be very specific. And then there's also this issue of judgmental or stigmatizing language. And I always like to refer people to the online Addictionary, ADD, at the beginning of dictionary for guidance on that. Or if you're wondering why it's important, that's an excellent resource for looking up terms. But what you notice in cannabis is I've been really careful about now not talking about I'm talking about legal or illegal markets or licit and illicit markets rather than using a color that might buy into some of our more racialization of drug issues in this country. So language matters and you need to pay attention to it. And it's something we all need to keep each other abreast of and hold each other accountable to. What about this co-use? Why am I talking about nicotine when you asked me to talk about cannabis? And it's because e-cigarettes and vaping devices can be used for both cannabis and nicotine products. And frequently what you see is people being more aware of the risks of smoking and tobacco and nicotine to babies and fetuses, and that's risky for women who are pregnant, but not necessarily patients understanding that cannabis has some of the same risks. And if you're not asking about whether people use vapes or what kind, when they use cannabis products, how did they use them, then you're missing opportunities to educate people. Another piece of this is that we don't have a lot of research on the equipment that's used. Vaping equipment has metal in it. It has plastic in it. There are chemicals in the plastic cartridges that you put in an e-cigarette. And the incidence of EVOLI, I always have trouble saying it correctly, but the e-cigarette vaping associated lung injury, or EVOLI, was a problem before COVID, where we knew people were having lung injury and they were being hospitalized, and there were people that died from this, but we really didn't understand what was happening or what was driving this. And we still don't know that it was all cannabis. We do know that it was related to vaping, and we do know that there's co-use of products. And we also know that these new vaping devices allow people to buy illicit market products and use them in devices. So in the end, with EVOLI, we did realize that vitamin E oil, which is used in a lot of cannabis products, was a problem, as well as the metals in the vaping devices. But we're still not sure that that was all, because not everybody that had EVOLI was vaping using products that had vitamin E. So there's still a lot of questions we haven't answered. But again, this is an arena that is very important to explore with clients, particularly if they say they're using cannabis products. So what are the risks of marijuana to developing fetus or the mom? Preterm birth, low birth weight, some of these things sound very familiar and are similar to tobacco and nicotine. Likelihood of the baby needing, being preterm or needing neonatal intensive care services. Long-term effects we're still not clear on. We need more research, but we believe that cannabis use during pregnancy can impact child development into adolescence and cause behavioral issues and attention issues. And for moms, you know, there are risks of cannabis-induced psychosis, dependency or addiction, or other mental health problems, particularly if women are using cannabis to treat other symptomology. Then stopping use can mean that those issues become more prominent, which those of you that do SUD treatment are fully aware of. So all of this means we need to caution women. We need to caution them that they need to be very careful and that it is not safe. There's no data that tells us that it's safe to use cannabis while you're pregnant or breastfeeding. The American College of Obstetrics and Gynecology has a really nice one-page flyer that we've given you a link to. And they've really outlined these risks very clearly, the risk to the fetus and then the risk to the woman. And these are the kinds of things that you need to have at the ready when you're having conversations with women. And you need to be able to cite where it comes from, right? Credible source. The American College of Obstetrics and Gynecology recommends that pregnant and breastfeeding women not use cannabis. Here's why. So we've talked a lot about how we have these discussions, and we're going to talk a little bit about best practices in just a minute, but wanted to circle back to the theme through here that perception of risk impacts behavior and choices around behavior. And we don't have a lot of funding in the space of educating pregnant and parenting women about cannabis. And even when we do have that, it's not necessarily being seen by the people we want to see it when you compare the other exposure they get on social media or on the news or from friends and peers about whether cannabis is a risk, right? And certainly many women may be using cannabis and not intending to be pregnant and then discover that they are pregnant and have to start thinking about this and getting more information. But when you approach these discussions, it's really important to know where you stand, be clear and transparent, and be open to asking women where they are coming from. Why are you using cannabis? What does it help you with? Why do you think it helps you with it? At the same time that we're being clear about what it means for a pregnant woman to be using cannabis and be in your program or be in your care or be under your case management purview. What are the confidentiality and reporting mechanisms that women need to be aware of? Do you have policies and procedures in place in your organization? My last clinical post, we did a number of plan, do, study, act, process improvement, a lot of projects that focused on how we communicated with our SUD clients in treatment about cannabis so that we could speak with one voice, so that we could be consistent, so that we understood where each other were coming from, so that we knew what the medical providers were saying and that aligned with what the counseling staff were saying. So these are all issues you need to be thinking about. And these discussions can be difficult, and you may have to make time and space to have them. Wanted to spend a moment on just what are the withdrawal symptoms that can occur with cannabis. As product potency gets higher, we're seeing more and more of these withdrawal symptoms. And withdrawal symptoms can be an indicator of dependency, but are not necessarily a diagnostic criteria, right? So withdrawal is one of the components of dependency. But anger, anxiety, depressed mood, decreased appetite, irritability, restlessness, difficulty sleeping. Some people even have experienced fever or chills and sweating. You may recognize these as also being some of the withdrawal symptoms for nicotine and tobacco. Not the same, a little bit different. These are symptoms that can occur within the first week of stopping. And if somebody started using cannabis because their family member uses it for anxiety and says it works, there's a cycle of thinking around withdrawal symptoms being a sign that you need to use more cannabis because the cannabis is treating your anxiety, if I just use that as an example. So again, perceptions of why people are using, how they perceive it affects them, and whether they have accurate information on the research on cannabis is really important to be asking about, thinking about, and have resources to share with people. So I wanted to take a moment and just do a poll. True or false? A predictor of marijuana use during pregnancy is perceived risk of use. Just give it a few more seconds. So most of you are weighing in as true, and some of you still believe that it's not necessarily a predictor. I think we can publish the results. Excellent. You can see most people are on the true. Some people don't believe it's a predictor. So let's talk a little bit about that. I'm going to close this. I'm not sure it's closed if everybody was seeing it. Sorry, I'm going to be able to see my slides. Ooh, too fast. So my colleague, Michael Sophis, and his colleagues at Dartmouth actually did a study on predictors of marijuana use in pregnancy. This is cited at the end of the slide deck. And what they learned from this, it was an online survey. They had the final number of women, pregnant women involved in this analysis was 296. about a third of the 296 women that completed the survey were in their first trimester of pregnancy. So there's a limit to what we can assume about this information, because many people haven't sought care or haven't had any interaction with healthcare providers in their first trimester. But basically, these women identified 41% of these 296 women said they'd quit as soon as they learned that they were pregnant. They quit using cannabis. About 13% said they quit, but then relapsed. In other words, they were struggling to reduce their use. About 32% said they had successfully reduced their use, not necessarily successfully quit, but definitely had reduced from their pre-pregnancy cannabis use. And about 15% said that they were just continuing to use at the same level that they had been using before they realized they were pregnant. What the questions were in this survey really said, asked women whether they perceived these issues on this slide as I apologize. What was asked in the study was perception of risk. Did people think cannabis was risky? And then they looked at that and looked at the correlates of perceived risk. So what we found from that analysis was that the factors you see listed here put these pregnant women at greater risk for continuing cannabis use in pregnancy. How much they used before they got pregnant and whether they used early in the morning was a factor. How old they were when they started using. Those of you in SUD treatment won't be surprised by this. Whether they thought using cannabis during pregnancy was risky, whether they rated use during pregnancy or prenatal and during lactation were really any risk to the baby or themselves. And then really interesting was employment status seemed to matter. Women who were not employed were at higher risk for continuing to use cannabis during their pregnancy. And then something I've already talked about, which is if they were using tobacco before they got pregnant, they were more likely to continue to use cannabis after they got pregnant. So this is just one study. We need more research. We certainly need more research on women who are pregnant and women who are pregnant throughout pregnancy, not just mostly in the first trimester. But it appears that understanding of risk of cannabis use in pregnancy is really important to whether people can succeed or make efforts or think it's important to quit. So I'm going to move on with time just to talk a little bit about best practices, mostly to make you aware of resources. I've said this before, but just because it's legal doesn't mean it's low risk or that it's recommended. So the messaging shouldn't be much different than what we already say for alcohol, although we have less research. We need to be approaching this with the idea that we're screening, intervening, and providing treatment and support for women who use cannabis. And the only way we can do that is if we're clear on what they're using and if they're using and why they're using and what they're struggling with if they're trying to reduce their use or quit. SAMHSA actually has an evidence-based brief that's 5 chapters that talks about the importance of using contingency management or rewarding reduced use and the use of testing. And I just want to make a comment here that brief is really helpful and goes through a lot of this in detail. But I know contingency management tends to bring up dollar signs when we talk about it these days, and points and vouchers and other ways to reward or incentivize clients are as effective and qualify as contingency management. And it's really about helping people move towards rewards other than feeling the reward of use. CBT, manualized programs, and working with women around beliefs, pointing out problematic assumptions, and helping people assess what their automatic thinking is around use is really not only effective for all substance use disorder, but has been proven effective with cannabis use disorder. And there are some manualized programs and approaches out there. Motivational techniques are key, and I think really important to building engagement, trust, and relationship in order to have people, pregnant people, be honest with you about what they're struggling with and how you can help and support them in their efforts to reduce and quit their use of cannabis or cannabis products. Open and informative conversations. This is based on I referred to the Academy of American College of Obstetrics and Gynecology, who also have a lot of good suggestions on how to approach women around this. And the last resource I want to highlight, which gets at this open and informative conversations about pregnancy use and post-delivery use, is outlined in a Colorado brief. This slide is really just to remind you that you need to be talking to people you're working with who are pregnant about afterbirth, not only about lactation and breastfeeding, but protecting babies from secondhand smoke, not using childcare providers that are under the influence, locking up products that could be unsafe, whether they're cannabis or otherwise, knowing how to contact poison control, and not putting children in cars with people who are driving under the influence. And last but not least, we all need to stay informed and up to date. So you and your organization need to be thinking about how you stay up to date on what your state laws are, what state regulations are, what your policies are, and how they align with what is allowed in your state and what your state allows as legal, or and how you manage that. If pregnant women come to you who have a medical card and permission to use and really believe it's helping them, how do you manage that in your program and in your care? This slide I'll let you look at, but this is just an example of a Colorado resource that John Hopkins wrote that gives you a good overview of screening questions, resources, research, lactation advice, and facts for women, like questions and answers like those you see on the slide. I'm going to stop there and assume we'll capture some questions as we move forward. And thank you for your patience. It's always hard to do these webinars when it's not able to be interactive. So I'll turn
Linda,
it to you.
Thank you so much. You gave so much great information. So I know I felt like I was interacting with you, even though I was just listening to a lot of the content, and covered an absolute lot of territory. I think what we're going to do is I'm going to introduce Carla. We'll do the scenario. I'll ask Carla a couple of questions, and then we'll bring it back for a couple of questions for everybody, rather than continuing with questions now, to make sure that we have time. So I'm going to introduce Elizabeth Carla Lemos. She is a senior program manager at Advocates for Human Potential and an implementation specialist for mobile crisis and justice interventions. She's a certified alcohol and drug counselor and has been delivering SUD services for more than 20 years. Her experience includes serving as a program director of a pregnant and parenting women residential program, director of reentry services for an agency on LA Skid Row, and supervisor for an SUD program for individuals while incarcerated. So if I can invite Carla to come up, and Carla's going to walk us through a scenario and kind of use more of the treatment perspective here. Carla, are you with us?
Yes, I'm here. Thank you, Deb. There we go. Thank you. So this scenario, we've been working with Rosa, a 20-year-old woman, for the past 12 months. Rosa is now 6 months pregnant with her first child. She's nervous and excited about starting a family. Prior to becoming pregnant, Rosa baked marijuana daily and drank to intoxication most weekends, sometimes even blacking out. Rosa previously reported that she stopped drinking cold turkey when she learned she was pregnant. While talking with her today, she tells you she decided to stop vaping and instead use edibles. She tells you while vaping might be bad for the baby, edibles are a completely safe and natural way to unwind. So based on motivational interviewing, what stage of change do you think Rosa might be in during this time? You can put your answers in the chat. Yes, preparation. Preparation is a great stage that you identified because she's in a place where she's learning how to take some information that she previously has had to stop using alcohol and to stop the vaping. Absolutely. Harm reduction, yes. What might you say to Rosa if you were using an MI approach in this situation? Maybe some ways that you might engage with her to learn more about the thought process and any information that she may have on using the edibles. Where did she get her information from? Exactly. And also, she is learning and preparing. That's fantastic. And you also might want to ask her, what are some things that she might want to see to maybe change how she unwinds? You might want to ask her, what is the need to unwind? Tell me more about what you've learned about vaping versus edibles. Pros and cons of her using, that's great. How often is she using them and why? I like what Tammy is saying. What areas of your life are causing the stress and the need to unwind? That's great. What might your approach, how might your approach be different if you used a CBT framework? Ask her about her goals, intention of purpose. So with CBD, we might be able to identify, is she experiencing any stressors in her life? And that may be leading to her need to unwind. Reflect. You want to make sure what you take is safe for your baby. Again, providing that information, looking at alternatives to helping her unwind, practice some of those techniques with her. I think those are all great answers. Thank you.
Thank you, Carla. Yeah, I really appreciate the answers and sort of thinking through, because she's starting to take action. She's starting to pay attention, but in making her decisions, is she making fully informed decisions? I really appreciate a lot of these answers. Carla, why don't, while we have you live, and then we can invite Linda to join in as well. Could you tell us a little bit about some strategies for engaging pregnant women in conversations about problematic behavior?
Yes, sure. So I think one of the things that I have found most effective in working with women with this population is really meeting them where they are. They come from several different diverse backgrounds. We want to know what the history has been, as Linda talked about, really learning what has been going on with them previously. How are they doing with their pregnancy? Are they getting medical attention? Really just trying to engage them and providing a lot of information. Some of the things that we want to work with women, especially in the early stages of trying to work towards change, is working on stress management, identifying some of those areas that may be leading to the stress and developing some coping skills to help them combat those stressors so that they can have better outcomes. Working on craving management skills, identifying some of those areas and providing a lot of support. I think we were going to talk a little bit about that, understanding who their support system is and how they can access that information.
Mm-hmm. And I think this starts to roll into it, but the next question that I'm going to ask you has to do with kind of treatment planning. What do you see, like thinking about this Rosa person or another woman with cannabis use disorder in your program? What are some of the elements of a treatment plan for a pregnant woman who is, let's say she's using cannabis, but she's not using other illicit substances or alcohol? What should be some of the elements of her treatment plan?
The treatment planning is one of the things that we practice a lot, was making sure that the individual has a mental health examination. That is really, really important. Providing psychoeducation on the uses of any substance, providing that information, and really working on stress management, getting them connected with some groups, getting them connected with other peers that might be in similar situations so that they can get that support system going.
Mm-hmm. Great, thank you. Linda, let me invite you to join the conversation with Carla. Is there anything that you would add related to treatment planning for women with cannabis use disorder?
Yeah, I think it's really important to also get a sense of what messages women are getting from their supports. So Carla's really highlighted an important thing, like where are her supports? And are those people that support her also a source of information or misinformation that, well, I used cannabis when I was pregnant with you. So why are they telling, why are you being told by the program that you have to stop? Or in my work with women in treatment, sometimes we spend a lot of time educating the woman, but not recognizing that they were getting pressure and messages from elsewhere that were affecting their ability to make changes or be successful. So I think that's an important one. I also think the doing decisional balances with women, because pregnant women in particular are getting pressure from so many different directions. And so, it's sort of a cognitive behavioral exercise, but what are the risks of continuing the same behavior? What are the benefits of continuing the same behavior? What are the risks of stopping or doing what you're being asked to do? And what are the benefits? And it's hard. I frequently would do that on a whiteboard or on a piece of paper with someone, just to get them to think about, all on one piece of paper, why they want to use, what is motivating them to maybe not use, and recognize that they're getting things from continuing to use that they need to pay attention to, and those are the places they may need to replace behaviors. Like if I'm getting stress reduction from my cannabis use, or I perceive that, then let's talk about other ways to deal with those feelings when they hit you. And to me, that's a way you can do motivational and cognitive behavioral work just by trying to get people to work through a decisional balance about cannabis use. A decisional balance really has to be focused on the one behavior you're working on. But I think that's a tool that people could use more.
Great, thank you. So one of the pieces that this question kind of asks is, what do you say a person who says that cannabis helps their anxiety, and they have to take something, and they'd rather take cannabis because it's natural than a medication that's made in a laboratory? Carla, would you like to respond first, and then we'll come to Linda?
Yes, I think that Linda really touched on the information that's out there, the research that shows that utilizing the edibles or these other things, still there is harmful risk. And so really providing that information, offering it to the clients that they are now made aware of the risk.
It's a tough one.
Linda,
Yeah, it's sometimes I think we have to like break it down into what's here and now. Like, okay, maybe I can't persuade you that this is risky in general, but during the time that you're pregnant, and if you're going to breastfeed, then, we and the research and the healthcare providers believe that you need to not use cannabis for the next 9 months, and if you're going to breastfeed. So making it not about never using cannabis again, which can get us into a tug of war and really induce resistance. So focusing it on, okay, right now in this moment, here are the reasons this is really important. And, you don't have to commit about what you're going to do afterwards, but then it gets to the slide you just pulled up, right? Like, so maybe you think you need this for medical reasons, but let's talk about once the baby's born, and if you're done breastfeeding, and I'm hoping that everybody's giving information on the benefits of breastfeeding and the importance of breastfeeding, instead of just saying, okay, like that's a discussion too. Like, but are you choosing not to breastfeed because you just want to use again? That, let's talk about that. But then this issue of, okay, what is, how do you reduce harm and risk for you and your children, right? Which is these issues of secondhand smoke, which is a risk. The research is coming out on this factor, and there are a lot. And again, if you think about the devices that are being used, right? So yes, is vaping less risky than lighting up a cigarette? Yes, it is. But that doesn't mean it's no risk. We know there's risk. Or, do you know what's in these products, and how do you make sure that, just like the bleach is locked up, any kind of medicinal or adult use products are out of reach and not appealing, or if they're appealing, they're in packaging that kids can't see it. It's a risk for children to get exposure. When states legalize, poison control calls and ED, emergency department visits go up, both for kids and for adults who use too much. So that's a discussion, and making sure people have those resources is really important. And then this issue of driving under the influence, we're seeing a lot of alcohol and cannabis co-use. We don't have enough research in this arena. We need more. We don't have a good way to judge if somebody's used recently and is intoxicated with cannabis like we can with alcohol. So education is really important.
Thank you. Yeah, I brought up this slide because I think it's important to talk about sort of two different parts of this. One is that you started to mention is thinking about the fourth trimester. So it isn't just the first 3 trimesters. And if you have somebody who's engaged in services, that fourth trimester after the postpartum period is a very vulnerable decision-making point for women who are engaging in recovery, as well as for families. So thinking about sort of how you're delivering services and considering in treatment planning, what's the plan for after the baby is born, because life is about to completely turn upside down. So that's one piece. The other piece that is important with this is this slide does not address all of the risks. And there are other risks related to having a newborn or a child. So, you know, in terms of the secondhand smoke, if you're not in places which are ventilated, yeah, there is a tendency babies get very sleepy. And some people have been known to actually use marijuana to help put babies to sleep in a place which is actually dangerous, because babies wake up every couple of hours generally for a reason. There's also some research that suggests that they may have growth delays or poor sucking, poor muscle tone if they're being exposed. And it's always hard to tell whether it's fetal exposure or exposure as an infant, or whether it's the environments that children are growing up in. Other factors, you know, is mom getting enough food during pregnancy? But there are some patterns that we see kind of correlated. One of the things when I talk a lot about alcohol is that we've done pretty good job of paying attention to driving under the influence is dangerous, but we don't necessarily think about parenting under the influence is also a little bit dangerous, right? So it does affect your motor skills and your coordination. It can affect some other, you know, just like other substances, it can affect what you're paying attention to. And, you know, dropping the baby or falling asleep are all also risks. So, you know, paying attention to making sure that the environment is safe and reducing accidents is also kind of an important piece of that. And engaging in an environment which supports, you know, for those women who do have a cannabis use disorder. And I completely agree about the importance of building in the harm reduction strategies. You don't have to say you're never going to use cannabis again, because that can feel overwhelming. Though it's also possible that in the motivational interviewing, as people start to do more, they also realize that their use of marijuana every day, their motivation for doing a lot of other things and moving forward with some of their other priorities, hopes, and dreams may have been diminished. So they may be entering more of an orientation towards a path of recovery and reduced use as well, and encouraging that. So what in their environment supports that, as well as being a healthy parent. Those things also end up being so important as well. So I wanted to kind of link that in. I want to invite Carla and then Linda just to give a closing comment, and then I think we can move ourselves forward.
Thank you, Deb. So I think overall, we want to help the client or the individual kind of recognize where some of their problematic thinking is, and help them more effectively work on those challenges. Help them create effective solutions, just like Deb was talking about. Does it need to be all the way just no longer using cannabis, or harm reduction? You know, what does that look like after the child is born, and you know what's going to take place after that? Those are really, really great points to talk about with the individual. That's pretty much what I have. Thank you. Thank you, Deb.
Thank you. And Linda.
You know, I think one of the things as a nurse, I'm always going to have a biased healthcare perspective. So I'll just acknowledge that before I say this. But I think it's really important to recognize that we as teams need to get on the same page or understand if we're not, right? So recognizing, you know, there are nurses who have worked in cancer care for a long time that now do cannabis on the side. Not all healthcare professionals are going to reinforce ACOG's stance on pregnant and breastfeeding women in the use of cannabis for medicinal purposes. There are people who have chronic pain issues, or have, you know, conditions that cannabis is appropriate for them to use. And at the same time, just like we have to have conversations with pregnant women about psychotropic medications if they have bipolar disorder, you've got to approach it from that perspective. Like, what are the risks and benefits? How do we weigh the risk to fetal development with your beliefs or your conditions and your need for medications. So from that perspective, I really encourage programs to consider conversations as teams, or building time in the team meeting you have weekly or supervision meetings, so that people can have a safe space to get more information, to make sure that, I mean, when we were doing process improvement around cannabis legalization in our clinic, we really had to educate the staff on the state law. We had to be clear about what we could and couldn't do as delivering services in a legal state. We needed people to understand what was reportable and what wasn't. We had staff who didn't think cannabis use disorder was a big deal. And we had staff that thought pregnant women who used were horrible. And how could we even entertain that they don't stop immediately, that we hold their hand while they reduce their use? So if you think it's difficult working with clients, it only gets more difficult if they're getting mixed messages from different providers and people. Mm-hmm. And how are you coordinating their care and making sure you understand what messages they're getting and integrating that and helping them make decisions rather than feeling like they're being faithful to you, but not to the obstetrician or to their mother or whoever else is in the picture.
Agreed. Thank you so much. And that brings us back to that first piece around having clear policies around marijuana with your colleagues as well, so that the treatment team does not send mixed signals. Today is Tina Fey's birthday, so I chose a quote from Tina Fey that goes right to this. Whatever the problem, be a part of the solution. Don't just sit around raising questions and pointing out the obstacles, but think about sort of how do you continue to move forward and encourage people towards recovery. As we mentioned, we do have 2 other webinars planned, and then we will be having the Learning Collaborative starting in July. You will receive information on the next webinar, but if you want to save the date now, you also have these links for the pregnancy one and then the one on pregnant and parenting teens. And I believe that those are the last pieces. We have contact information here for Linda and Carla, and then the resources that you'll be able to look at. I want to thank everybody here for coming and for all of the work that you do with women. Thank you so much. Have a great day.
Take care.